a couple things I think are real important when you look at this class of drug. It developed by a concerted effort in cancer drug development to look at new agents that would be effective based on the mechanism. And then once they found a drug in this class that was beneficial, they further modified it to try to get better efficacy and less toxicity.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Rowena Schwartz, Professor of Pharmacy Practice at the James L. Winkle College of Pharmacy at the University of Cincinnati in Ohio, about the Nitrosourea drug class. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Mo, and welcome.
Thank you. I love talking about drug therapy, so I really appreciate the invitation.
Wonderful. So to start things off, can you give us a brief overview of the history of nitrosoureas in the field of oncology?
I think I can. These are old drugs. In the 1950s, the alkylating agents kind of came of age. And there was an effort by the National Cancer Institute to look for other agents that would be effective. And they actually developed the murine model to test these agents. So a prototype of a nitrosourea was tested. They saw a lot of activity, some toxicity that we'll probably talk about. And so then eventually BCNU or carmustine was studied in the 60s and finally approved for the treatment of brain tumors in the 1970s. And so a couple things I think are real important when you look at this class of drug. It developed by a concerted effort in cancer drug development to look at new agents that would be effective based on the mechanism. And then once they found a drug in this class that was beneficial, they further modified it to try to get better efficacy and less toxicity.
Thank you for sharing that. And I think it's so interesting just, in that approach of looking at chemicals and compounds and things that already existed and trying to kind of retrofit them in a way to help fight cancer versus the space we're in now is more with a deeper understanding of what drives cancer development and growth, kind of intentionally now creating compounds to fight that. And so it just was a very interesting time, I'm sure, very challenging time in cancer care of trying to find these compounds that not only were effective, but were hopefully limited in the toxicities, which we will talk more about here shortly. So can you describe to us a little bit more about that mechanism of action that we see with the nitrosourea drug class?
So it's interesting as we talk about this because these drugs developed because they were alkylating agents. And so when you say nitrosourea to me, I still go to the pure, these are alkylating agents. And alkylating agents, just as a little bit of a reminder for people that don't think about this every day, are those drugs that add an alkyl group, which is a carbon with 3 hydrogen. That's an alkyl group to DNA. And when it adds that alkyl group to DNA, you get DNA strand breaks, you get interruption of repair. There's a number of different things that occur. So these alkylating agents that we have, and we have a lot of them, that's a kind of consistency how they work. But with the nitrosoureas, there's something really interesting because there's another mechanism that has been identified. And that is that when you put these nitrosoureas, in the body, they break down into intermediates. And one of them is an isocyanate. And the reason that's important, and I'm going to kind of give a little bit of the scientific aspect of it, but then just kind of go to the nitty gritty, how I think of it, that these isocyanates, what they do is they inhibit DNA repair, therefore have an impact on cells that are damaged. You can think of it as a second mechanism. And people that work in the neuro-oncology space think of this when they think of drugs like lomustine in brain cancer, how that drug decreases the DNA repair protein 06-alkyl-guanine DNA transferase. And so again, we found these drugs because they're alkylating agents, but as we've used them, because our understanding of drug therapy has so advanced since 1950s, we find new ways that they work. Maybe a little boring, but I think pretty fascinating myself.
Well, I think interesting because, again, for nurses, understanding that context and being able to kind of translate that information into something that makes sense to our patients is really important. So while we might not all be able to get quite that deep in terms of our understanding or maybe passion for understanding that level of depth, I think it is important so that we can appropriately explain our patients who are getting these drugs, how are they different from other drugs they're receiving, whether it's in the same regimen of therapy or a subsequent line of therapy, just being able to kind of speak intelligently about like what these drugs are, how they work, and how they're different from other drugs the patient might get, because ultimately it will connect to the symptoms and side effects that the patient might experience. So I appreciate taking us down a little bit deeper into the granular aspect of the science, because I am also like you, I kind of nerd out a little bit over it. So thank you.
The other thing to think about too is that, when we talk about alkylating agents, like the huge class of alkylating agents that we have, the nitrogen mustard, a lot of times when we talk about the different subgroups of them, it's based on like their chemical makeup. But one of the things that I think is really important is that nitrosoureas don't have a lot of cross resistance with other alkylating agents. And that's a concept to realize that these other mechanisms may play a role in the fact that you can use these drugs for patients who have progressed through other alkylating agents.
So let's talk a little bit more about maybe some of the subclasses of the nitrosourea drug class. And can you maybe highlight a few examples of notable agents that are commonly seen?
It's funny because as I thought about these drugs, I actually went and made sure that I was aware of the drugs that are currently available in this group. And in the United States, I think of 3 agents, and they are carmustine and lomustine. So a lot of the nitrosourea has that mustine at the end. And then the other drug that kind of fits into this group is streptozocin. Streptozocin is a nitrosourea, but it's 2-glucosamine. So though it is a nitrosourea and how it works, it is selectively taken up into the beta cells of the pancreas. And that's where we use this drug in pancreatic neuroendocrine tumors. So it doesn't have the ending of lomustine and carmustine, but it is a nitrosourea. And so when I think about way back when I was in school, I always used to think of these drugs as the BCNU, CCNU, and then there's other drugs that are not available now, like methyl CCNU, and there's other ones that are available in other countries. But we don't have a whole lot of these drugs currently in practice.
So let's move on to some of the common toxicities and adverse events that we know are associated with nitrosoureas, maybe both as an individual agent or subclasses when they are given. What are some of those common toxicities that patients experience?
For me, this is probably one of the most important aspects of this group of alkylating agents. These drugs are very lipophilic, meaning they cross the blood-brain barrier. That's why we use them in brain tumors. So that's one of the key things. That's also one of the toxicities we see when drugs cross the blood-brain barrier. We see neurotoxicity. So that's one to at least always consider, but also the benefit of it crossing over and being able to treat cancers within the CNS. When I think of nitrosoureas, I always think of the impact on bone marrow. These are myelosuppressive drugs, but there's a nuance here that is different than other chemotherapies. These are drugs that nadir 4 to 6 weeks after administration. And the reason that's really important, if you ever look at a clinical trial and they're talking about how long it can be since patients receive chemotherapy, they often will give a longer time for nitrosoureas because of that long impact on bone marrow suppression. At high doses, you can get permanent bone marrow damage. So this is an important toxicity. Nausea and vomiting. Back in the old days, this was like what we used to say when we talked about these agents. We have good antiemetic therapies now. So this is not like a game changer as much. Pulmonary toxicity. So alkylating agents tend to be DNA damaging agents and they can damage tissue throughout the body. So nitrosoureas have pulmonary toxicity that can occur years after treatment. It has hepatotoxicity that you can see again over time with increased dose, cardiotoxicity, and kidney toxicity. So they are organ damaging agents. And that's one of the reasons that when we use these agents, we have to be very aware of monitoring required for patients.
I really appreciate the distinction of not only, acute toxicities that you mentioned, but also recognizing that they can happen later, after therapy is concluded, more of a delayed presentation. And so that's important for nurses to understand, even if it's not maybe an agent you're actively giving to a patient, if they have received that in a prior line of their therapy or maybe at a different institution, just something to keep in mind as their treatments continue.
I think that is a key point. Knowing that patients have received these really make a difference later in your care. I think that's a great point, Jamie.
So what are some of the pharmacology-related strategies that are used to help prevent or manage the toxicities that you just discussed?
I think one of the key things is patient selection. And I think that's looking at patients and realizing the risk associated with the drugs and to see if there are specific risks for the individual patients. Counseling of patients, we're going to talk, I'm sure, about that. That is key to help patients realize that they need to help with the monitoring for these kind of side effects. And then I think engagement of the entire care team. These drugs are not commonly used. Maybe if you're neuro-oncology focused and that's all you do, you may have some experience with the drug and therefore feel comfortable. But I would say that most oncology practitioners, these are not the drugs that they know intimately. So I think engaging the whole care team to understanding the risks and the toxicities and the need to monitor over time and to jump in and do aggressive management and evaluation if toxicities occur.
I think because we know the availability of so many different types of cancer-directed agents, whether it's oral, we've got immunotherapy, we've got cell therapies now, there's so many to choose from. And if you're in a generalist infusion center, you're seeing a little bit of everything every day. And so some of these older drugs, as we've mentioned, you might not see as often or maybe once in a career. So I think it is important to always kind of just take that moment to pause and ask, what is this drug that I'm giving? Do I know what it is? Do I understand how it's different from what I am used to? And as you said, making sure the entire care team is on board of understanding what this agent is, how it's given, any nuance or unique things about that drug that need to be kept in mind, because the landscape of cancer care is increasingly complex for all clinicians, nurses, pharmacists alike. And so it's never a bad thing to pause and bring up the package insert, familiarize yourself with what this drug is, especially if it's not one that you've seen before or you've not seen recently. So let's talk a little bit about the actual administration of these drugs. What considerations should nurses keep in mind when administering nitrosoureas?
As a group, these drugs are alkylating agents, so definitely safe handling is essential. And, with DNA damaging agents, that means anybody who is going to come in contact with these drugs. So carmustine is given intravenously. Lomustine or CCNU, those are capsules. So handling is different depending on the agents. Carmustine is an interesting drug. It's actually reconstituted with dehydrated alcohol. And so, especially when you're using larger doses, this is used not very commonly, but still used sometimes in some conditioning regimens prior to stem cell transplant. So when you're using those larger doses, it's a high amount of alcohol. And so just being aware. It's so funny that you said you may only see these drugs a couple times in your career. I can't say the word carmustine or BCNU and not think about a patient I had who had a history of alcoholism. And when he was getting his BCNU as part of his conditioning regimen, did get drunk and he was an angry drunk. And so it was bad. And so I think that it's always important to be aware of that alcohol content. There's also flushing of the skin that has been reported, probably related to that alcohol content. So flushing, facial pain, headache, hypotension, if the drug is given too fast. And so that you'll notice in some of the transplant regimens, they're given over a prolonged time versus when they're given for other uses, not so commonly anymore, they're administered over a couple hours. That's a key thing with the BCNU administration. Also the risk of nausea and vomiting, those kind of things, and also the risk of extravasation. The thing with the lomustine or the CCNU capsules, the thing that's really important here is that the dosing is really different than how we normally give oral medications. And so it's really important that patients are aware of exactly how much they take and not that they don't repeat the dose every day. So I think just like with other oral regimens that are not daily, we really have to make sure patients are aware of the specifics of how they take the drug.
Absolutely. It's so interesting that you brought up having the alcohol content as part of kind of mixing that dose of the drug, and the larger doses kind of present a more predominant risk of patients feeling like they're intoxicated when they receive it. That has come up recently, and I think in a couple of other drugs, and the actual drugs right now are leaving my mind, but it's just so interesting that is something that, again, for nurses, if they are not in an environment where they are actually participating in admixing the drugs and doing that, which I think fewer and fewer nurses are in that role, which I think is all for the better, partnering with our pharmacy and our pharmacy technician colleagues to do that work that they are so much better trained for. But I think that's an interesting piece, because if we're not the ones understanding how that drug comes prepared or what is part of that combination, is that those are some of the things that might not be as evident to nurses. And so that's a great example of that communication between pharmacists and nurses about understanding what parts of that puzzle maybe they might not have the visibility to, but it does become an important teaching point for our patients to know what to expect. And as in the example you gave of understanding a patient's history, and are there different preparations or just awareness we need to have when we're giving this drug, especially at higher doses?
It's funny. I can go back to that room in my head, and it's been years ago, because although I knew it, I just wasn't prepared for it. I do think when you don't give these drugs often, and I did not give this drug often when I was working in bone marrow transplant. So if you do not do this frequently, it is important to review. And I'm thankful to ONS for having all those resources available for practitioners that they can review fast. They don't have to go and read the entire package insert. They can really look at the key things from some of the resources available to practitioners.
Absolutely. So kind of along those lines, we've kind of worked our way into the patient education piece, and then kind of what information is important for us to ensure that we're sharing with our patients and their caregivers so that they feel prepared. So can you talk a little bit about those primary points that we need to make sure we communicate to patients and caregivers about their nitrosourea drugs?
Yeah, and I think it's very dependent upon which drug it is, in terms of the immediate toxicities as well as the long-term toxicities. If you're talking about lomustine, an oral agent, that's going to be a little bit different. You're going to have to really focus on what the regimen is like, how long it's going to be given. But I think even for talking about the class, one of the things that we need to make people aware is that it is likely that if you have toxicities, your doses may be adjusted, because these are agents that if you have toxicities in terms of bone marrow suppression, there is recommendations for dose reduction, and it's not simply that you would give a growth factor. So I think helping patients know what the toxicities are short-term as well as long-term really are the important aspects to communicate before, during, and after patients are treated.
Thank you for that. I think those are some great points to consider. And I think patients will have questions, as they always do, but the more information that we can prepare them with so that they just have that awareness, I think they're better for it. I think we've given some great examples, but let's talk a little bit more detail about how pharmacists and oncology nurses can really collaborate to manage not only the adverse events and toxicities, but also provide education and really serve as a trusted source of information for patients.
One of the things I think is really important is that there is some standardization in your practice of how these drugs are used, because I look to see what order sets we had built out for these agents at UC. And that helped me because it helped me really see what education would be required. Sometimes because we don't use order sets as much for oral drugs, we may not have that built out. So I think establishing standard approaches is going to be really important for these agents, whether you use them every day or you use them very infrequently. It just gives you a consistency about how you teach patients and how you monitor. And then you can also develop strategies for how you manage toxicities. Just today, I was talking to one of the providers I work with, and they told me something they had learned about treatment strategy that I had not heard. And I thought, I was surprised. And he said, well, you always like hearing ways that we can make it better. And that's what I do. I like that kind of standardization in the team. So sharing things that work with the team members also, I think, is really important.
You emphasized a great point that you had talked about earlier, is that there's an oral agent and an IV agent that fall into this class. And so I think what we know is operationally, those can sometimes be completely different nursing staff. If you're an office-based or clinic-based nurse, maybe in a coordinator or a navigator role, you are more heavily involved in the oral medication piece. Obviously, if you work at an infusion center or if you're an inpatient nurse actually administering the IV medication. So sometimes those are distinct populations and staff of nurses. And so it's going to be important for both sets of those nurses to understand what they need to know about these drugs. So many of our drugs we know are given IV, but just as many now, maybe even more, are given orally. And so just thinking through, as we collaborate with our pharmacy colleagues, understanding that the nurses that need that targeted education might be housed in different locations and kind of have a different sort of framework for their daily activities. So I think it's important, as you said, to create those standardizations and make sure the nurses that are working in those environments kind of understand those tools and then collaborate with each other. I mean, again, these drugs might be given in different ways, but if there are tricks or tips or just important information that nurses can share with one another in those different environments, we're all the better for it, for just understanding what we can learn from others' experiences. So what do you think the future looks like for these agents and their role in the landscape of cancer care?
I don't know. I mean, I hate saying that. I like to have an answer for everything. But, these agents cross the blood-brain barrier. So I think they continue to have a role in a very difficult clinical situation. Patients that have cancer in the CNS, whether it be because disease crosses over or starts there. So I think because of that lipophilic nature, these agents, that's why, although they're very old, are still used the first line, often used like second line or third line because of the toxicities. But I do think that they keep a place in therapy. Do I think new drugs are going to be developed? I'll never say never, because one of the things I've learned in life is that when we think we know how something works, this is an alkylating agent, we find out that it has impact on DNA repair. And so that opens a whole new door for where these drugs can be utilized.
Well, we never know, but that's what keeps oncology interesting, is that every day is an opportunity for a new drug to be approved and a new indication. And just when you think you might have it figured out, then the next week you realize you don't, because something new has come down the pipeline. So, but that's what makes it fun. That's what makes it never the same day.
That really is what gives you hope.
Absolutely. Well, Mo, thank you for your time with us today. You're a regular on our podcast and we love having you. I always learn a lot when I hear you kind of dig deep into the science, and I always appreciate that perspective that you bring. As we reach the end of our episode, we'd like to visit with our quick fire questions just to help summarize and wrap up what we discussed. So to start that off, how do you think healthcare professionals can evaluate maybe their hidden or their implicit bias when dealing with nitrosoureas?
I think the hidden bias is that these are old drugs and therefore have no place in therapy. And I think that bias is dangerous because when we use them, we don't know the nuances that we need to know for our patient care.
What are some common misconceptions about nitrosoureas?
That because they're alkylating agents, they're like all other alkylating agents. And I hope we've highlighted that these are not like all other alkylating agents.
What's something about this topic that's not often discussed, but you wish people knew more about?
The long-term toxicities to different organs. I think the topic of, liver toxicity, pulmonary toxicity, one of the things I hate most in life is pulmonary toxicity, cardiotoxicity. I wish we knew more about them, not only for nitrosoureas, but for other drugs as well.
What additional training or education do oncology nurses need to stay current on this topic?
They need to know where to go to find information that will be helpful to them and to the people that they're caring for quickly, because this is not something that they are going to remember necessarily. That's fine. It's not about what you remember from school or what you learned. It's what you find when you need it and can be able to interpret it in a way that helps patient care.
Absolutely. This is an open book test. Like, there's no prize for having it all memorized. But as you said, knowing what are your trusted resources, how can you access them efficiently, find what you need, and then be able to share that with your teammates or with their patients and caregivers. I couldn't agree more. Finally, what are some additional resources maybe for patients or other providers who want to learn more?
I would say there's definitely drug information out there for patients. I think that where I would look at it, and I will defer to my colleagues in neuro-oncology to look at where the drug is used to learn more about why it's used in that area. And that's going to be within the specializations, whether it be in transplant for lymphoma, for CNS lymphoma, or if it's going to be in neuro-oncology for gliomas.
Well, Mo, thank you again. I always love your visits to our podcast, and I look forward to the next one. Do you have any final comments to share with our listeners today?
I would just say that it is really helpful to revisit these topics that we don't see every day to keep them fresh in our mind. And that even though this may not be a class of drug you see often, when it pops up, it's great to have at least a foundation to understand the information. So thank you for giving me that opportunity.
Thank you again for coming to share your knowledge. And I think this will be a great resource for nurses as they do continue to stay fresh on all these very unique drug classes that we see. Thank you again for your time today, Mo.
I enjoyed talking with you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.